biologic. On the screen is some of the demands of immunosuppression therapy and those. Biologic anti-TNF, we should know about the brand name. The very important name is adalimumab. Adalimumab is one of the first and unique FDA approved for treatment for treating of the uveitis until now. In summary, on the screen is a phase of treatment plan: topical corticosteroid, systemic steroid treatment, DMARD, and some kind of the anti-TNF alpha. In children, a little bit different compared with adults. We should using immunosuppression, some demands sooner and more earlier compared with adult, because if we delay the systemic immunosuppressor therapy and we make sure more cost for caring and for treating pediatric patients, even this could decrease the quality of life. On the screen, I would like to show about the guideline American College of Rheumatology 2019, and as a research, very big research on care for uveitis focus. Many guidelines adjustment in the world, but one of very important guideline is consensus-based recommendation for management of uveitis associated with GIA study based on over 1,000 research in the world, and they have consensus. Very important that the topical and systemic NSAIDs have no effect as monotherapy in terms of the treating uveitis, and topical corticosteroids as a first-line treatment for anterior uveitis. Please remember that topical corticosteroids is the first line treatment of anterior uveitis, and systemic immunosuppression is recommended for inactivity of uveitis during steroid dose reduction. Methotrexate until now is the first choice as systemic immunosuppression. In case of the methotrexate inefficacy, we can switch to the biological treatment like anti-TNF. And using anti-TNF therapy is recommendation for the patient who not working well with the DMARD therapy, especially in methotrexate already. We can see that the 12 of the consensus recommendation, but please remember some very important thing below. We already talking about the methotrexate. Methotrexate until now is the first choice for DMARD treating of the pediatric uveitis. But methotrexate have a lot of complications. Sometimes it's very difficult to use in eye hospital, eye center, for example, our hospital, because of they must indication in terms of rheumatic disease, and at the general hospital and the injection intraven or muscle injection only. We can switch to another demand like mycophenolate. Mycophenolate nowadays is more common day by day. The brand name is Cell-Safe and very easy to use for oral Cell-Safe at the eye hospital. A lot of research compared with the methotrexate and Cell-Safe, and the conclusion that the efficacy is equal, even though some research talking about the Cell-Safe is better and the efficacy is faster than methotrexate. The very interesting that at the slide I only mentioned 12 or 20 drugs very popular and global sale in 2019. Who is know some kind of the 20 drugs? Before searching on the internet and find some knowledge in uveitis section, I by myself only know about the number 5 earlier, the number 8 Avastin. That's all. But you know, the first and very big money to buy in all of the world 2019 is Humira. Humira is the first one, and nearly 20 billion US dollar per year for Humira. But why Humira cannot use in my hospital? Some of you already heard about Humira before. And now I just mentioned that Humira is one of the very important drug to deal with the pediatric uveitis. And some research focus on the Humira Visual 1 and Visual 2 trial. In conclusion, I just to talk about the pediatric uveitis is very complex, chronic, and challenging condition for not only patient, parent, even the physician. The two things that early immunosuppression make a good outcome for the children's life in terms of chronic uveitis. And the third thing I want to give to the Professor Dong and leader in our hospital. We should need to do the research, focus on the immunosuppression therapy in treatment of uveitis in our hospital. Thank you.
Thank you very much, Dr. Fu, for your very comprehensive presentation. We have learned about the symptoms, the signs, and the diagnosis of uveitis, and also how we can treat this kind of disease. So let me change my position like this. So it's easier for me to control who come out, who in. No, let's talk it. Everyone can go out if you want. Yeah, it's free. Yeah. Please,
Yep.
and it's my turn. Okay. Yes. So yeah. So we have a lecture about uveitis, and it's a non-infectious uveitis. So I think now I just want to change the format of the symposium. I don't want to ask expert. The expert will answer you later. So I want to ask the young doctor, the resident. Dr. Fu now, he's an experienced doctor. He had a lecture on the non-infectious uveitis. So what do you think about the lecture and what you have learned from the lecture? Can you say your opinion, Dr. Mai Thiên Tâm? I see your name here. Are you here, Dr. Tâm?
See there.
Dr. Tâm? Are you here? No? Dr. Quang, can you tell me who is Dr. Tâm? Or she disappeared also? No, because here. Dr. Lan Anh, are you here? Resident? Yeah. No? Dr. Thanh Huyền also. Are you here? Yeah, okay, thank you very much. So two of you gone already. So what do you think about the presentation and what you have learned from the presentation? Can you share with us? Let me explain why I asked the resident first. Because you are a young doctor. And I'm sure that your English much better than our one, the old one. Okay? So please share your opinion about the lecture, what you have learned from the lecture. That's very, very simple, right? Yes.
Thank you so much for your presentations. I think it is a good presentation. From your presentation, I can learn more about pediatrics, non-infectious uveitis. It's a difficult disease that I think it is difficult to face to. According to your presentations, I can learn about the science, the system of the pediatric uveitis, and I can learn the difference between the pediatrics and adult uveitis. And in addition to that, I learned more about the treatment of the uveitis and the different difference between the treatment in the world and in the Vietnam right now.
Can you tell us what was the difference between
Okay.
the guideline of Vietnam and the guideline of the international guideline? Dr. Fu said the topic of the presentation is the update of the treatment. But can you recognize what is the updated one?
In Vietnam right now, we only still corticosteroids.
Yeah.
Osmos is the only drugs that we use right now. But in the world, they use more drugs like DMARS, like cell-sap, neurons, or methotrexate. And the guidelines say that they don't use corticosteroids is the first line. They use methotrexate or DMARS is the first line.
It seems not correct. Professor Chi or Dr. Châu, could you add some information relating to issue the question? She said that in Vietnam, we use only corticosteroid to treat the uveitis, and we don't use immunosuppressor. Is it correct? Can you say something, Dr. Châu? Yeah.
It depends on the patient.
Yeah.
First line we use it depends on the anterior or posterior.
Yeah.
In anterior, we only use the topical steroid, and if the posterior we think is immunology is recurrent, we use the systemic corticosteroid.
Yeah.
And if the patient we try to do it maybe recurrent the new exposure, and if it's even if the children, if after 2 or 3 times we could send to the pediatric hospital to ask about the immunology. And if they it depends on the pediatrics, they decide to do with them and follow the uveitis in the eye.
Yeah, thank you for your comment. So, so we can see that for our patient, we treat locally with corticosteroid, and if it works well, it's okay. But if it doesn't work, you can send the patient, you can refer the patient to pediatric doctor, and they can give the systemic treatment, including corticosteroid or immunosuppressant, right? Do you agree with that, Dr. Fu?
Is some right or some wrong?
Yeah.
Yeah,
Right as is like gold standard treatment.
Yeah.
we send patient to the pediatric hospital, but we have difficult things that in pediatric hospital they don't have indication using DMARD for uveitis.
Yeah.
Then they send back patient to our. That means we send patient take around and only corticosteroid treatment only.
So, what's our situation?
Our,
According to you? Yeah.
our situation now that we not a rule
Yeah.
for DMARD treatment in terms of the pediatric uveitis. Not until now we don't have indication for treatment using DMARD in our hospital.
Yeah. But what I know that in some hospital, if the patient have a uveitis and also have a GAI,
Yep.
so the patient may be treated with immunosuppression also.
Yep.
Yes, not only. So it means that in some place we use both locally and systemic, right? Thank you. And I'd like to ask some other resident. Dr. Phương Dung, are you here? Perfect. Your English is very good, so good. Can you say something about the presentation and what you have learned, or your comment about the presentation? Dr. Fu, it's very good point. I learned a lot from you, and this one is not good, so be correct it for this time. Please.
Well, first I want to thank you so much, Dr. Fu, for your presentation because I can review the knowledge about not only pediatric uveitis but also general uveitis, for example, glass infection. And I also have a updated latest knowledge about the treatment of pediatric non-infectious uveitis. Yeah.
So what you have learned from his presentation? Did you learn something?
Yes, as I told before, I have the latest update of how to treat case of pediatric non-infectious uveitis. For example, how to use steroid and some other agents. For example, as I remember, yes, anti-TNF agents for treatment pediatric uveitis.
Yeah, that's true. So from Dr. Fu's presentation, you can see that they use anti-VEGF, such as Avastin, yes, and IDEA, we call it IDEA or IDEA, yeah, to treat uveitis, right? Even Avastin.
Yeah. So anti-VEGF is one of the intravitreal to deal with the CME, and we can use another kind of drug like triamcinolone as well, or dexamethasone implantation.
Yeah. So the purpose of the anti-VEGF here to treat the inflammation or to treat the complication of inflammation such as the CME.
Yeah, the aiming to decrease the concentration of VEGF in vitreous and decrease the CME as well.
Yeah.
The second thing, some complication of CME or chronic posterior uveitis like neovascular
Yeah.
we can using the anti-VSF.
Yeah, thank you, Dr. Fu. So Dr. Hung, I'd like to have your comment or your opinion. You are expert on the uveitis, so please.
Thank you, Dr. Fu, for your very well presentation. First one of my comment is I agree with Dr. Cho's comment that for the treatment of uveitis, we must define on two main, that it's the infectious or non-infectious uveitis. That's very important. The second one, we have to define that is the anterior or posterior uveitis. It's very important when we treat the patient. If the patient only has the anterior uveitis, we only need to treat with the local steroid and with atropine for the patient. And for the topic that Dr. Fu present today, I think that the new treatment like anti-immunosuppression or another biotic therapy is for the very rare case where the patient had many period of recurrent uveitis. And the one important that we all know, or someone know, that methotrexate or another immunosuppression has some defect general for the patient. So we have the very tight correlation with the internist, the doctor, to better follow up for the patient. And for that's the more thing I want to comment. The second one is that for the intravitreal injection, like Avastin or Alia for the treatment of CME, is only for treatment of symptom of the patient. So this not the wide treatment is only had the patient had many time of recurrent and CME, DME, CME macular edema is in the recurrent and chronic case, and Avastin or Alia is add-on treatment to recover the vision of the patient. For the corticosteroid intravitreal injection like dexamethasone implant like Ozurdex, it should not recommend in the children because the young patient has the lens very clear, and dexamethasone implant can cause the cataract, and sometimes it's very difficult to control the IOP. Yeah, I think that's all.
Thank you very much for sharing your experiences and your knowledge. So the point of view is different from doctor to doctor. I think it's very normal. Yeah. Doctor, do you want to add some comment or something relating to the topic?
Thank you very much, Dr. Fu. I think treatment of pediatric uveitis have many challenges and difficulties, especially in eye hospital like us now, because we have to do many laboratory tests to find the reasons, but for patients, if they was paid by insurance, the general hospital, like pediatric hospital, can do the test for them, and for the treatment of DMARS, we have to base on the pediatric doctors to observe the side effect when treatment. So it's quite difficult to treat uveitis in eye hospital. So At that time, for the patients, many patients have to do the test without insurance, and it's cost a lot. Yeah.
Thank you for reminding us about that, relating the cost of the examination and the treatment. And we can see that uveitis, non-infectious uveitis, that is not only eye disease, it also a systemic disease. So we have a cooperation between the internist or pediatric doctor and eye doctor, so to treat the patient. Is there any comment or question from the other doctor? I'd like to have two opinions from our senior doctor. First, Professor Van Eyck, do you have any comment or question relating to the presentation? We are very happy to have your opinion. And then I'd like to invite Professor Thuy. And look, Professor Thuy can speak Vietnamese or English, it doesn't matter. Please.
Thank you, Dr. Phu, for your presentation. And I'm very interested in the comment of Dr. Hưng. He gives us a larger picture about the treatment of non-infectious uveitis. We must care about the side effect of the treatment. And besides of the CNE, like Dr. Phu said, we must care about the IOP and the cataract when after the long time treatment. And the system style and system disease, we must care about the joint, like Dr. Hương said. And because the side effect of the DMARD, so I think we cannot treat the DMARD here in our hospital, because there are a lot of side effects. We must care about the hematology and other things. So I think we should join with